ascending and descending loops, all in the same picture, doing a variety of things with molecules, sodium, potassium, chloride, bicarbonate moving in and out across these membranes. I find the countercurrent mechanism to concentrate the urine to be absolutely remarkably brilliant. I doubt if any man could have designed it. I mean, it's just unbelievable. I used to teach that the reason man had kidneys was to allow the animal to live out of the sea, and then some biology major told me that fish also have kidneys. I guess it's only one reason that they have kidneys. There really are three reasons we have kidneys. What are they? Filtration of what? Yeah, we have to have them to get rid of the bad stuff, right? We have to have them to get rid of, if all we ate was carbohydrate and water, we could get rid of the byproducts by just running and breathing. Because the byproducts of carbohydrate is water and CO2. So we have to have kidneys to get rid of the byproducts of the metabolism of protein. Since we are carnivores, we gotta get rid of the byproducts of the metabolism of protein, which are ammonia and hydrogen ion. So we gotta get rid of that acid. And the other reason we have kidneys is to maintain our fluid volume. It reabsorbs most of the sodium going through, so we reclaim. So did you know that there are animals, I don't know what they are, but there are animals living in Australia who have a 1 milliequivalent sodium diet a day, and their urine output has 1 milliequivalent sodium a day. If you take in 600 milliequivalents of sodium a day, your urine should have 600 milliequivalents of sodium in it. If you have normal kidney function. It's fascinating. The other reason that these two lectures today are, I think, difficult is that the terminology, I think, is confusing. The terminology we're going to use to try to describe these diseases is confusing. So bear with me and you'll need to try to find a way to conceptualize these illnesses other than memorizing words, because the memorization, I think the memorization of words is just too much overlap. We'll try to talk a bit about that as we go through. So, if you have questions, if some of this doesn't make sense, my guess is it won't make much sense. But if you can think of good questions, just go ahead and ask them, and I'll see if I can answer them. Okay, tubulointerstitial diseases. So, these are a group of diseases where the illness or the pathology is either in the tubule, which is that business of the descending and ascending loop of Henle, and then the collecting duct, and then that goes into the ureter, which winds up in the bladder, which winds up in the toilet. So the tubules are these loops of Henle and the collecting tubules, okay? That's the tubulo. And then the interstitium is all that stuff that's out there between the tubules and the vessels, capillaries. It's just called interstitial space, right? And what happens in most of these tubulointerstitial diseases is that the body is invaded by something that sets up an inflammatory response that primarily affects the tubules and interstitium. That's really the concept here. Okay? And then you'll have to sort of memorize the categories of things that do that. There's no other real way to do this, as I can say. Now, sometimes these can present as acute diseases. An acute disease would present as someone comes into the office because they have been feeling really, really bad for 2 or 3 days, or they saw some blood in their urine. Acute illness would be defined by us most of the time as days or weeks. Most tubulointerstitial diseases present as chronic illnesses. They've been there a long time before the patient recognizes them, or you pick them up on an examination for something else. The patient doesn't even really know they have it. Chronic diseases are defined as months to years. Days and weeks is acute, months to years is chronic. Most of these tubulointerstitial diseases present as chronic illnesses, but they can present as acute illnesses. So this is the picture of the thing that confuses me the most. You know, you got all these blood vessels, and you got these tubules, and you got this interstitial space. In this picture, the interstitial space is the white background. It's just that stuff surrounding the tubules, surrounding the vessels, surrounding the capillaries that can get inflamed. Okay, so how do tubulointerstitial diseases present? They present with a decline in GFR, and the way we pick that up is what? How do we know that someone's GFR is down? They have what? Decreased
urine output.
Urine output. No, that almost never works, because if you just drink nothing, you'll have a decreased urine output. So the amount of urine you're putting out doesn't really help unless it's really high. Really low doesn't help.
What if you drink the same amount? If you drink the same amount all the time, would it?
Yeah, then you'd be weird.
But physiologically.
Physiologically, if you drink the same amount all the time and you ate the same amount all the time, your urine output would be the same all the time. Unless you got in a hot environment, or unless you start running real hard in the Oklahoma heat in June. So, urine output isn't really important unless it's really high. The way we figure out whether someone's GFR is down is their serum creatinine is elevated. So we stumble upon it by drawing a blood test. The reason that doctors and PAs and nurse practitioners and people who are trying to figure out what's wrong with people do these comprehensive metabolic profiles is to kind of see, is there somewhere I can figure out to start? And they're measuring some of the more common things that might go wrong. And serum creatinine and BUN are on there, right? So the way we figure out that there's a decline in GFR is the serum creatinine is elevated. My wife can't figure out why I won't take water on a run or a walk. I take some on a bike ride because I'm out there 2 or 3 hours, but I don't drink it very often. She can't figure out why. I said, because all it does is make me pee. Why would I just keep drinking water? I only need that I'm losing. And if I can get through with this activity in an hour or two, I'll just sit in the cafe and drink water where I've got access to a bathroom. I don't drink water or Diet Cokes on an airplane for the same reason. I don't like those little bathrooms. I just don't want to go, so I just don't drink. Okay, so decline in GFR. For tubulointerstitial diseases, this can be caused by obstruction of tubules due to crystals or due to something. It can be damage to the microvasculature. Remember that the glomerulus is a small vessel, right? It's a capillary specifically set there. But there are capillaries all around the tubulo system. And so microvasculature that can be damaged by things other than the glomerulus, capillary damage. And then the big one is interstitial fibrosis. This is a sloppy, ambiguous term but it's important in the pathology of tubular interstitial disease. For whatever reason, exposure to certain things can cause fibrosis of the interstitium. And when you have fibrosis of the interstitium, fibrosis just means the development of fibrin, right? It just means the development of stuff that's not supposed to be in there. And it interferes with the movement of water and electrolytes between tubules and blood vessels and across membranes. Yes?
I blinked because I was thinking too hard. The first bullet point, is it supposed to be 3 bullet points, or is it damage to microvascular is like a sub-bullet point, or?
Yeah, damage to microvascular is a bullet point.
Okay, so there should be 3 bullet points.
There are 3.
Okay, because I was like, oh, okay. Thank you.
Because obstruction of tubules damage to microvascular doesn't make any sense.
That's what I blinked.
All right. Now, in this slide, there's a little bit different heading. This is leading to. There's an abnormality in the proximal tubules in these tubular interstitial diseases. And what happens when you damage the proximal tubules is you interfere with the reabsorption of glucose, you interfere with the reabsorption of phosphorus, uric acid, bicarbonate, amino acids. So there's a lot of problems with movement of molecules across the tubules, mostly reabsorption. You can't get to the stuff that's coming through. You have a normal anion gap metabolic acidosis. Have you studied wide and narrow anion gaps? Yeah? Yes? Okay. So tubular interstitial diseases present with normal anion gap metabolic acidoses. How can you tell that your patient has a metabolic acidosis? I'm sorry?
Look at CO2.
Look at the CO2, which is really not CO2, it's bicarbonate. So you look at the serum bicarbonate on your blood test, and it's low. If it's low, the patient probably has an acidosis, right? They have a metabolic acidosis. To know that it's a normal anion gap metabolic acidosis, what's the next molecule you look at? Chloride, because it has to be high. If that anion gap is normal, but the bicarb is low, the chloride has to be high, because that's how you define the anion gap, right? So these are hyperchloremic metabolic acidoses. They always have a high chloride. Other things might be going on, but that's the easy way to figure out. And they may be proximal RTA, or they may be distal RTA. In the proximal RTAs, the problem is you can't reabsorb bicarbonate. Most of the bicarbonate that is filtered through the glomerulus is reabsorbed in the proximal tube. With distal RTA, the problem is you can't secrete hydrogen ion into the urine in the distal tubule. Okay? Now the patient may be polyuric. The patient may come in and say, I'm getting up 2 or 3 times to use the bathroom at night, and you're thinking, well, they probably have diabetes, so you do a finger stick blood sugar and it's normal. The reason they may have polyuria is they can't concentrate their urine. Because of this interstitial disease, because of this interstitial fibrosis, they have trouble moving water in and out of the collecting systems so that they can concentrate their urine. They have proteinuria. And this is because most of the things that damage the tubules and the interstitium also damage the glomerulus, but they don't damage it to the extent that you get nephrotic amounts of protein. So what you have is usually less than 2 grams per 24 hours. Okay? Tubulointerstitial diseases usually have less than 2 grams of protein in the urine in 24 hours. And then they have anemia because whatever's occurring in this tubulointerstitial disease damages the cells that produce erythropoietin. Any questions about these phenomena? Okay, so now we're just going to run through some slides that talk about this list of diseases that cause this. There are some autoimmune diseases: sarcoid, Sjogren, and SLE. Have you studied sarcoidosis at all in pulmonary? So sarcoidosis usually presents primarily as a lung disease, but it can present as a renal disorder. And Sjogren syndrome, how do these people present? Dry mouth, dry eyes. It can affect the tubular interstitial. And SLE generally presents with arthritis, with a variety of symptoms that sound more like arthropathy, but commonly affects the kidney and usually affects the glomerulus more than the tubules and interstitium. But SLE can affect any part of the kidney. It can present with nephrotic damage to the glomerulus, or it can present with tubulointerstitial problems. Okay? If you had a patient that was presenting with what you thought might be SLE, how would you work them up? An ANA, an anti-nuclear antibody, a double-stranded, anti-double-stranded anti-nuclear antibody is the test of choice for SLE. Now, here's the other problem with these kidney diseases. Commonly, not necessarily here, but commonly you have to have a renal biopsy to figure out what's going on. In these 3 diseases, with the autoimmune disorders, they're usually, if they come in with renal disease due to an autoimmune disease, they usually have symptoms of the autoimmune disease other than the kidney. So you're placing your bets. You're saying, well, they have dry eyes, dry mouth, and they have all the syndrome of Sjogren syndrome in terms of their eyes and their mouth. So this stuff they've got going on with their urine probably is Sjogren syndrome. Now, you don't know that for sure because you haven't biopsied them and you haven't got a renal consult, but it's probably what's going on. Sarcoidosis will usually have these granulomas in the lungs. They'll have granulomas on the chest x-ray, or they'll have big lymph nodes on the central aspect of their chest x-ray. Then they come in with this decreased GFR and they got these things going on. SLE is the same way. There are toxic causes. There are a lot of toxic causes, but these are the 3 primary: lead, cadmium, and mercury. And exposure to these atoms set up an inflammatory response in the tubule and the interstitium. I would just memorize those 3. I would guess they would not choose other than these 3 on the PANSS exam.
Where do you get exposed to cadmium at?
Well, I don't know now, but cadmium was a really common atom to be used in the race up to the atomic bomb.
Okay.
And so if you live around Santa Fe, New Mexico, you might get exposed to cadmium. If you lived in Tennessee, you might be anywhere close to where they were experimenting with fission nuclear chain reaction. I don't know about today.
Well, but I guess if those people are still alive, so.
There are some of those people still alive. Yeah. We are still alive. Mercury, you just have to eat fish. Almost all fish are totally intoxicated with. I wouldn't eat any fish, any from anywhere. Only hamburgers. I love Big Macs. Hereditary. Okay, so there are a couple of categories of hereditary. You can be born with medullary cystic disease. And medullary cystic disease is an illness that's congenital, it's genetic, and it presents with these cysts that occur in the interstitial of the kidney and lead to a decrease in GFR pretty rapidly in early life. Mitochondrial disorders, which we won't go into, but those are also genetically determined. And then there are some malignancies in which tubulointerstitial disease is more common. Leukemia and lymphoma can do this because what happens is the leukemic cells and the lymphoma cells can infiltrate the tissue of the kidney, the interstitium. And malignancies associated with monoclonal gammopathies can do this. Monoclonal gammopathies, have you heard that term? No. So a monoclonal gammopathy is a syndrome where a B cell clone has gone rogue and is making a specific type of gamma globulin. Okay? And they're called monoclonal gammopathies. And they used to be, back in the late 70s, late 70s, early 80s, they were thought to be benign. But as it turns out, almost all monoclonal gammopathies eventually turn into a malignancy of some sort. How would you know that someone might have a monoclonal gammopathy, for God's sake? Huh? Of what? It would be a good idea to biopsy. It's always a good idea to biopsy, but this one's, huh?
They don't have to.
They might, but they usually don't. So what is a gamma globulin? It's a protein, and if you've got a B cell clone making gobs of it, such as happens in Waldenstrom's gamma globulinemia, then you've got gobs of protein. And so serum protein will be high. And it's on that bunch of tests that you get called, what's it called these days? Chem 18, Chem 24, Chem 75, what? Comprehensive metabolic profile. Is that what they call it? It's just a whole bunch of tests that are thrown in there by, someone chooses them. It doesn't make a whole lot of sense. Multiple myeloma is a type of monoclonal gammopathy, but it's a plasma cell line instead of a B cell line. Okay? Now, infection related. There are a couple of things. This is just a list. It's not exhaustive. So there are other infections that might cause tubular interstitial disease. And the one that's not on this list, well, it's down there, chronic pyelonephritis. The one that's not on this list or even mentioned in this lecture is pyelonephritis. Have you studied pyelonephritis yet? Okay. So let's talk about pyelonephritis. So you've talked about urinary tract infections, where someone gets discomfort when they urinate. The discomfort is being caused by inflammation of the ureter, and the discomfort is caused by inflammation due to usually E. coli that's in the bladder, and it's setting up an inflammatory response, and that inflammatory response is causing trouble with the lining of the ureter. So you go to urinate, and it kind of stings, or it feels uncomfortable, right? If that infection stays there and doesn't get addressed early enough, or if the bacteria that's causing it is hypervirulent, that infection can travel up the ureter and into the kidney. Once it hits the kidney, it can cause inflammation and infection outside the wall of these collecting tubules and into the interstitium. So probably the most common tubulointerstitial disease is acute bacterial pyelonephritis. It's a really easy diagnosis to make because the patient comes in sick, acute bacterial pyelonephritis. They come in sick, they feel bad, they look bad, they have a high fever. If you haven't been taught to, have they been taught to do the urogenital exam, or is it coming up? Professor Brooks? Is the genital urinary exam coming up, or has it already been done?
On Tuesday.
Huh?
On Tuesday.
On Tuesday, okay.
Are you talking about the nephrology portion or the urology portion?
No, I think they're the same, are they not?
No,
The physical.
Yeah.
Physical exam.
Oh, the physical exam is Monday, the lecture's Monday. We're doing the prostate and cath on Wednesday.
Yeah. So let's talk a bit about physical exam for pyelonephritis. So the patient comes in, they look really bad, they've got a high fever, they have vomited twice, they have a little bit of dysuria. You always are going to always get a CBC and a urinalysis. The urinalysis comes back packed with white blood cells. And you say, oh my God, this is a urinary tract infection. But they're sick. They look really sick. Most people with a urinary tract infection don't look sick. They aren't sick. They just have burning in their pee, and they take 3 days of antibiotics and they're well. But these people with pyelonephritis are sick because their kidneys are infected. Now, you'll most likely be taught by someone that the way you pick this up is the patient is sitting on the table and you hit that area just underneath the ribs, and it's called the costovertebral angle. If you do that, and if they have pyelonephritis, you'll either get an elbow in the jaw or sued for too aggressive practice. It's unbelievable that that ever became a physical exam thing. I can assure you that if the kidney's infected, the capsule around the kidney is so sensitive neurologically that all you have to do is put your hands back there in the costovertebral angle and do this, and they'll go, oh God, oh. All you got to do is push on them. You don't need to hit them. It'll be demonstrated in every physical exam book. It'll be told in every lecture that's done on this disease. But if they're febrile and sick, I wouldn't hit them. And if they're not febrile and sick, I wouldn't hit them anyway because you're not looking for anything. Just don't hit patients. It's just not good. All right, so that's pyelonephritis. That's acute pyelonephritis. Those people almost always have to be hospitalized. They almost always have to have IV antibiotics until it gets cooled down. And that's usually caused by a gram-negative bacteria. And it is a tubulointerstitial disease. It's not on the list. What's on the list are a whole series of things, except for the last, chronic pyelonephritis. It's a whole series of infectious diseases where the patient presents with some sort of chronic something wrong. You're working them up and you find pyuria, you find white cells in the urine, and you say, well, you got a urinary tract infection, we'll wait for it. We'll start you on that bacteria, this is usually E. coli, and you'll get well in 2 or 3 days. But the culture comes back negative. So you've got what is termed in the literature sterile pyuria. The question is, what causes sterile pyuria? It's a trick question because it's not really sterile. It just didn't grow in the way that you tested it. So when you get a urine and you send it for urinalysis and culture, they're only culturing it for gram-negative bacteria. They're not culturing it for TB, they're not culturing it for brucellosis, they're not culturing it for fungus or Epstein-Barr virus. So the lab says this is sterile pyuria. Okay, so this list, except for the last one, chronic pyelonephritis, this list are the things that can cause sterile pyuria. The kidney is the second most common organ to be infected by tuberculosis. The first is clearly the lung, and we think of it as a lung disease. But the second most common organ to be infected by TB is the kidney, and they present with sterile pyuria. And they can present with no other organ involved. They can present with TB of the kidney and no lung disease. So white cells in the urine means infection. How about if you have an infection in the bladder but it doesn't affect the kidney? Do you have white cells in the urine? If you have just a bladder infection? Yeah. You do, because that infection calls in some neutrophils, right? And the neutrophils come flying into the bladder and try to kill the bacteria. But if you think that the infection's higher up in the kidney and infecting the tubules and the interstitium, what might you look for in the urine besides just white cells? What? Might be some protein. Yeah, there might be some protein, but it's not as helpful as something else. White cell casts. The casts are formed by the tubule itself. They are white cells that are formed into the shape of the tubule. You can see red cell casts, you can see white cell casts, you can see myelin casts, you can see casts of a variety of things. And what that means is the problem is up in the kidney. So white cell casts are a urinary finding of pyelonephritis, or of one of these chronic infections of the kidney. Any questions about these various infections? Just need to familiarize yourself with the kinds of things that can cause renal infection with a sterile urine when you send it off for there's white cells in the kidney, but they're in the urine, but there's a negative culture. Okay, now medication-induced causes. There are a lot of medicines that can do this. Analgesic nephropathy is usually caused by people who are just taking enormous amounts of some analgesic, and it's usually an aspirin-type molecule or one of the NSAIDs. Both NSAIDs, I don't think aspirin's on there. But analgesic, cyclooxygenase 2 inhibitors, they're all off the market now except for one, Celebrex. But if someone were abusing Celebrex, taking too much of it, it can cause a nephropathy. Any NSAID abused too much can cause a nephropathy, and so can aspirin. Okay, phosphate nephropathy, oxalate nephropathy. Calcineurin inhibitors. Have you studied these at all? Calcineurin inhibitors, we're going to talk about that a lot more in the next lecture. Calcineurin inhibitors are drugs, I think there are 2 or 3 on the market now. These are drugs that are used in transplant biology. And what they do is they inhibit the differentiation of T cells. Transplant rejection is caused by T cells attacking the new transplant, right? And so these calcineurin inhibitors are drugs that inhibit these T cells going after something. Okay? So they're T cell inhibitors. Lithium is a drug that is used in manic depressive disorder. How does lithium, you know, it's a pretty common molecule. An atom sits up there by sodium, right? On the table. You got that table memorized? Yeah. Lithium sits up there by sodium. How do you suppose lithium was determined to be effective in psychological disorders?
Someone eating rocks.
Huh?
Someone eating rocks.
Someone eating rocks?
Yeah. Minerals.
Might have been coming from the town you came from. So they were looking for sodium, they were looking for salt substitutes in heart disease. And they thought, well, maybe, what about lithium chloride? It's easy to make, it's same size as sodium chloride. So they made it, and lo and behold, it tasted a little bit like sodium chloride. So they started using lithium chloride as a salt substitute in people with renal disease and congestive heart failure. And they started noticing that people who had been having a lot of depression and anxiety got better. And so someone recognized that and said, we need to do some randomized control trials looking at lithium chloride as a treatment for, and they found it's still today, I think, the treatment of choice for manic depressive disorder, isn't it? Maybe?
It has some wicked side effects. I think they're moving away from it.
Yeah, they don't.
It has wicked side effects, and that's if your level gets too high. They're not moving away from it. They're looking for other molecules. Problem is, there aren't any other molecules that are working very well. But anyway, it's a commonly used psychiatric medication. Cyclooxygenase inhibitors started causing heart attacks, so those were taken off the market. Celebrex is the only one left, and then NSAIDs. So medication, the list of medications is real important. When someone shows up with one of these tubular interstitial diseases, you got to pay attention to the possibilities of infections, possibilities of any of their medicines they're on. Manifestations we've already talked a little bit about. They have a decline in GFR, so they have an elevated serum creatinine. Proximal tubular damage. Fanconi syndrome is a genetically determined proximal tubule abnormality. Normal anion gap metabolic acidosis. They might have polyuria, they might have proteinuria, they may have anemia. Now, the problem with this business is it's like all clinical medicine. It's really super ambiguous. So they may have one of these, they may have two of these, they may have all of these. You just can't tell. When these diseases are discovered as a chronic syndrome, treatment's very difficult. If they've been exposed to lead for years, if they live in Flint, Michigan, and they're 15 years old and they've been drinking that water all their lives, they're liable to be in trouble. They may have lead nephropathy that isn't treatable. However, treatment of the underlying cause can prevent further deterioration and sometimes reversal. So you need to look really, really careful for toxins, medications, and infections, because those are things you can change. You can't change their parents, so you can't change the genetic abnormalities, but toxins, medications, and infections you might have a shot at probably not reversing this renal damage, but maybe preventing it getting worse. Questions about tubulointerstitial diseases? Escape and hover.